Good afternoon, everyone, and welcome to the Bariatric Surgery second webinar series. And we are from the University of Iowa Bariatric Surgery Program in Iowa City, University of Iowa Hospitals and Clinics. Welcome to you all. In today's talk, I would like to emphasize some of the important things that have changed the field of bariatric surgery over the past couple of decades. Number one, the minimally invasive approach. And number two, the metabolic aspect of bariatric surgery, or the metabolic impact of bariatric surgery. And third, the centers of excellence nationally that have improved outcomes and safety and the culture of the specialty. This is our surgical team. Jessica Smith did her initial training in New Mexico, Albuquerque, and then did her bariatric surgery training at the University of California and San Francisco. And then Dr. Peter Now was a medical student at our institution here before he did his surgical training in Ohio, and then did his bariatric training at Mass Gen Hospital affiliated to Harvard University. And I did my medical school in Bangalore City in India, Bangalore Medical College, and then did further training in England for a few years, and then worked and trained at Northwestern University and Rush University at Chicago before joining the faculty here. Many of you might not know, but our Department of Surgery here at the University of Iowa has a significant place in the history of bariatric surgery. In 1966, Dr. Edward E. Mason conceived and performed the first gastric bypass for severe obesity. And therefore, our department is considered the birthplace of obesity surgery, and Dr. Mason is widely regarded as the father of bariatric surgery. He dedicated his entire life to helping the severely obese patient, and he's also the founding president of the American Society for Bariatric Surgery, which in fact changed its name more recently to the American Society of Metabolic and Bariatric Surgery to emphasize the metabolic impact of surgical weight reduction. Additionally, in the year 2000, our department performed the first laparoscopic gastric bypass in the state of Iowa. Dr. James Maher, who was the director for several years, and Dr. Cornelius Doherty, who was a past president of the society, and I, the three of us performed the first gastric bypasses in the month of May 2000 here in Iowa. In this picture here, you see Dr. Cornelius Doherty in 1981, along with Dr. Edward Mason at a meeting, at a bariatric surgery meeting here. In 1991, the National Institutes of Health, also called the NIH, had a consensus development conference where they announced that obesity is a disease. Prior to that, it was a widespread belief that it was not a disease but just a behavioral problem. However, the NIH not only confirmed that it was a disease, but also went on to say that gastric restrictive or bypass procedures could be considered for well-informed and motivated patients with acceptable risks. And they also stated that there is a low probability of success with non-surgical means. The NIH criteria of bariatric surgery include a body mass index above 40, normal is between 19 and 25, or a body mass index equal to or above 35 with associated complications such as diabetes, high blood pressure, etc., or 100 pounds above ideal body weight or twice ideal body weight. In our program, we currently offer mainly two procedures: the laparoscopic gastric bypass, the Roux-en-Y gastric bypass, and also the laparoscopic sleeve gastrectomy. This is the surgical anatomy of the Roux-en-Y gastric bypass. First, we use a stapler to divide the stomach at this point to create a small pouch, and this is the restrictive component. And then the small bowel is divided, and the distal small bowel is taken up and hooked up to the pouch, and the proximal small bowel was hooked up to the jejunum with an anastomosis to re-establish continuity of the bowel lumen. This pouch is the restrictive component of the procedure, while the bowel bypassed here, where the food goes down without mixing with digestive juices, and this bowel here, where the digestive juices reach this point without mixing with food, that is the malabsorptive component. Therefore, the gastric bypass is a combined restrictive and malabsorptive operation. And there is also a third aspect, which is over recent years a new dimension in its impact on obesity or weight reduction, and that is the endocrine and neurophysiological effect of these changes. Changing the anatomy like this also makes certain changes in the hormones in the body and the neurological pathways that also impact not only diabetes but also several metabolic aspects such as diabetes, etc. And this is the sleeve gastrectomy, where we use a stapler to divide the stomach from this point all the way up to create a narrow tube, which is called a sleeve, and this is approximately 20% of the volume of the stomach, and the remaining 80% of the stomach is resected and removed. Therefore, in the sleeve you only have a restrictive component but no malabsorptive component. On the other hand, you do have an endocrine aspect where the resective component, that is resecting this part of the stomach, also has certain endocrine and neurological impact on the metabolism of the body and impacting the complications of severe obesity. This is a diagram showing the open operation. In the open surgery, a large incision was made on the front of the stomach, and the entire operation was done through this open technique. However, the open technique caused numerous complications. First of all, the wound-related complications such as fluid collections and horrendous wound infections where the entire wound had to be laid open, and it took several weeks to heal, and that was quite difficult both for the patient and for the surgeon. And then in the long term, you had incisional hernias appear in these open wounds, and at least 1/3 of the patients needed a second operation, most often with insertion of a mesh to repair that hernia. Hospital stay was 4 to 5 nights, and recovery was several weeks. Nowadays, it's occasionally used for patients with previous open surgeries where, because of the scar tissue from the previous open surgery, it is difficult to do the laparoscopic approach. But in our program, we perform many of our laparoscopic revisions where previous open surgery, where bariatric surgery was performed. For example, the commonest example is a previous operation called a vertical banded gastroplasty, which was done open in the 80s and 90s. And many of those patients have now to be converted either to a bypass or to a sleeve. And even though they were open surgery in their first operation, in our program, we approach them laparoscopically. And we spend a lot of time, very often more than 2 hours, taking down the scar tissue laparoscopically before we start our operation. And to the best of my knowledge, we are the only program doing laparoscopic revisions of VBGs and other revisions in the state of Iowa. On the other hand, the laparoscopic approach is a minimally invasive approach. Here, we use several ports. After insufflating the abdomen like a tent by using carbon dioxide gas, through this port we insert a video camera and watch the interior of the abdomen on a video screen and perform the surgery. And these two ports are for the surgeon's right hand and left hand, and that port is to retract the liver. And here we have a surgeon's assistant port. So through these keyhole incisions, approximately 5 to 6 in number, we perform the entire operation. The gastric bypass done laparoscopically is one of the most complex, minimally invasive operations done today, and it needs a lot of training to be done safely. The incisional hernia rate is extremely low. We've had 0 for several years because of the technique that we use now. But the holes are so small and they close so completely that it is not possible to have a hernia through this for the rest of your life. The infection rate is extremely low, much less pain, recovery is quick, and there are much less adhesions or scar tissue in the body. So the gastric bypass has the restrictive component and the malabsorptive component, while the sleeve has the restrictive component and also a resective component. On the other hand, it is too early to tell whether the bypass or the sleeve is the best operation, whether one is superior to the other, or whether in the long run both will be options and there will be specific indications for one or the other. And the reason for this, the reason for it being too early to tell, is because we have more than 50 years of history with the gastric bypass, while with the sleeve, with the laparoscopic approach in large numbers and with long follow-up duration, we have very few patients because the sleeve really became popular over the past few years. On the other hand, the complication rates from the more complex operation, which is the bypass, are coming down. One argument or debate against the bypass is that it is a complex operation. But then if the complication rates of the bypass are coming down substantially, then it is still an option to be used. So at this point, I would say that the choice of surgery should be individually tailored for each patient based on the patient's individual circumstances and the surgeon's experience and outcomes. The lap band, on the other hand, is kind of going out of fashion. It was mainly pushed by the private industry and with a lot of advertising, but really, if we look back, too many patients who've had the band inserted have had to have it removed or converted to a bypass or a sleeve. And the complications are many. So I call it the band on the run. The possible complications are band erosion into the stomach, slippage, leaks, tube-related complications, port site infections, flipped port, esophageal spasm and dilatation, reflux. Repeated adjustments of band is necessary, and there's a high removal rate and conversion to gastric bypass or sleeve. One of the main metabolic impacts of gastric bypass is seen in the treatment for diabetes mellitus type 2. It made headline news in February 2007 when the NIH issued an official statement that gastric bypass surgery is better than insulin in the treatment of diabetes mellitus type 2 in the morbidly obese. Also, the gastric bypass is the international gold standard for several years. The benefits of surgical weight reduction are many, and it reduces the related problems of severe obesity, such as sleep apnea, high blood pressure, diabetes, asthma, joint pains, stress incontinence of urine, hyperlipidemia, which is high cholesterol or triglycerides, heartburn, which is GERD or gastroesophageal reflux disease, and even migraine, infertility, and hyperlipidemia can be improved significantly, as shown by papers published from our program. Many of these problems resolve 80%. Now, this slide shows a summary of the outcomes of the American College of Surgeons, who collect national data, and here we have the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, which is run jointly by the American College of Surgeons and the American Society for Metabolic and Bariatric Surgery. And this data is data from our program collected by the college and compared to the rest of the centers of excellence in the country. And here we see numbers from January 2013 until December 2013. Incidentally, the 2014 numbers have not yet come out. So during this period, our program performed 95 laparoscopic gastric bypasses. And here you will see that the gastric bypass related readmission rate was 0. The bypass related intervention was 0. Bypass related reoperation was 0. All cause reoperation was 0. Bleeding and leak was 0. Therefore, with 95 gastric bypasses in 1 year, with 0 leaks and 0 bleeds, 0 interventions, 0 reoperations, and 0 readmissions, Our program has established itself amongst the cream of the best programs in the country. And this data is collected nationally and audited and comparing each program to the other programs in the country. So the recommended plan for obesity surgery, you see a dietitian, start an exercise program, and then stop bad habits like drinking too much of pop and snacking and smoking. And if you come to the University of Iowa Hospital, you will experience excellent patient education, very low complication rates, being one of the safest programs in the country, and long-term or even lifelong follow-up. Here is a success story. This patient started off at 250 pounds with a body mass index of 43, and she worked full-time as an accounts manager. She had borderline hypertension, heartburn, stress incontinence, and other problems. And 1 year after a gastric bypass, she came down to 131 pounds. She lost 120 pounds and gained a husband. And she follows a diet and exercise regularly. All her comorbidities resolved. And even with the infertility that was present before the operation, she had a 3-year-old a few years later. Now, bariatric surgery will only work if you work with it. It is not a cure, only a tool to help you reach your goals. Therefore, you need to be educated well, you need to be compliant, go to a program where there are safe outcomes, and then in the long term, you need to continue the education and follow-up, where you go back to your program and keep an eye on things. There are several centers of excellence designations in the country, and the Center of Excellence is the third factor that has impacted the popularity of bariatric surgery over the past several years. Number one was the minimally invasive approach. Number two was the metabolic approach. And finally, the centers of excellence that started in the country also impacted everything because of the improved outcomes and the criteria for becoming a center of excellence. And this is our program team here, where we have 3 surgeons and coordinators and nurses and physician extenders. And we also have Chris Melichar, who works on the insurance pre-approval, and Amy is our dietitian. And today, Dana will address you, and Dr. Peter Na will also talk to you.